WFAE, Charlotte's NPR news source.
It's Charlotte Talks on listener-funded 90.7 WFAE and 90.3 WFHE. I'm Mike Collins. Until recently, actually until last month, livers donated in the Carolinas were likely to stay here in the Carolinas, but last month a new law changed the rules, allowing these donated organs to be transported within a 575-mile radius. North Carolina benefited from the old way of doing business. We have the sixth largest donor registry in the country, and some are concerned that this rule change may be detrimental to us. As we speak, 112,000 people are on the national transplant waiting list, while last year there were less than 40,000 transplants. Dr. Mark Russo will help us navigate the world of transplants and help us make sense of the impact of this rule change. He is the medical director of liver transplantation for Atrium Health, and he joins us now in our Spirit Square studio. Welcome. Thank you for being here.
Thank you for having me.
Explain how the liver donation recipient process has taken place up until this rule change took effect. How did it work?
Sure. First, let me recognize and be sensitive to the issue that as we use the word donor, these are loved ones of family, friends, mothers, daughters, and sons, and brothers that have experienced a tragedy, and the family or relative is making a gift of life and donating an organ. With that said, we're going to be using words like donors and donor-eligible deaths, which we'll explain. But prior to the change, and this really pertains to liver transplant, but some general principles are transcend into heart and lung and other organs. But prior to the change, and this past February, livers were shared in a relatively local area called the donor service area, which was defined by the organ bank called the Organ Procurement Organization. And for the Charlotte area folks, if they needed a liver transplant, most of that sharing happened locally at basically western North Carolina. However, if there was a sick patient, even prior to this change, a very, very sick patient, which is defined in a certain way, then there was broader sharing, even prior to this change, what we call MELD Share 35, where organs or livers were shared over a 5-state area.
So why did we do it this way? Why did we used to do it this way? Why were donated organs relatively boxed into a specific geographic area?
So it was mostly had to do with organ preservation. Once an organ is removed from the body, like a liver, it could only travel so far before it can't be used because it's out of the body and not receiving blood.
Time is of the essence.
Time is of the essence, and as science and technology advanced, preservation solutions allowed us to keep an organ like the liver out of the body for longer periods of time so they could travel further distances.
Now, this whole system is a little confusing to the average person. I was certainly confused. I read all about it yesterday, and I still don't understand. So let me ask you some questions about the system. The Organ Procurement and the Organ Procurement and Transplantation Network, OPTN. They kind of run this, don't they? Who are they?
So the OPTN and HRSA, Health and Human Services, Department of Health and Human Services, they contract with UNOS to administer this policy.
And UNOS is United Network for Organ Sharing.
Yes, so UNOS is the contractor for the government to administer the OPTN policies. So these are policies, not laws, that the United Network for Organ Sharing guides the distribution and transplant of organs like the liver.
So would it be correct in saying this was not a law change, this was a rule change by these which organization, the OPTN or the United Network for Organ
Well,
Sharing?
through UNOS. UNOS is the organization that addresses and changes the policy.
And both of these are non-profit organizations.
Correct.
They're not governmental organizations. They work in association with the federal government.
Correct.
Who gives them the power to set rules?
Well, they're contracted with the Department of Health and Human Services, but for decades, it's been since really the mid to late 1980s that UNOS has had this contract. So there's really only been one nonprofit organization that has administered their transplant policies. But oversight is through the Department of Health and Human Services. However, you haven't heard much about organ donation until recently, and hasn't become contentious until recently because most of the time these policies have been addressed and negotiated through the physicians and surgeons.
And that's no longer the case?
Well, what happened, a significant event happened a few years ago where a lung transplant recipient sued UNOS for the policy of distribution of organs, of lungs. Mm-hmm. And this then cascaded into the other organs, lawsuits involved with heart and liver. Prior to that, the courts were not involved in policy with organ donation. This was settled among the physicians and surgeons. But this now these new rule changes actually went to courts to help decide the policy, because the medical community cannot negotiate among themselves.
Is that new, that the medical community cannot negotiate among themselves as a result of these court rulings?
Well, the reason they went to court is because of the lawsuits. But prior to a few years ago, all these policies were negotiated among the physicians without the courts getting involved. After that, it's led to the courts.
So under the old rule, organs donated in a certain region would usually, 9 times out of 10, stay in that region. Under this new rule, the transport of livers from deceased donors will now be offered, or these livers will now be offered to the most urgent transplant candidates within a radius of 575 miles. That doesn't sound like it's that far away. If you're sitting in the heart of Charlotte, where would that radius take you? New York City, Philadelphia, Atlanta?
So as far as New York, it's 500 nautical miles, and so that circle's drawn about where the donor is, and it's typically the donor is at a hospital when they expire.
Right.
So that circle's drawn around the donor hospital, and that's as far north as New York.
So why are people afraid that under these new rules, it will cost the lives of people in the Carolinas? Because that's what some people say. It will cost the lives of people in the Carolinas who are waiting for transplants. Why?
Well, there's two important issues here. One is that organ donation rates are very high in general in the South. In particular, LifeShare, our OPO that recovers the livers, does an extraordinarily good job at discussing organ donation at the time of a terrible tragedy with the family. So our organ donation rates are very high. Why did this issue come up? Well, there's not enough organs in higher metropolitan areas. So they say they could do two things. You can try to increase organ donation in those areas and narrow the discrepancy between high donation areas and low donation areas. Or you can pull out organs from high donation areas to low donation areas. And that's just the general philosophical difference, is that why not try to improve organ donation rates in some of these high metropolitan areas that have low donation rates, rather than remove organs from high donation rates and transport them to low donation areas.
Well, let's talk about that, because that actually surprised me. You would think that in a major metropolitan area like Manhattan, New York City, that in the environs, that there would be an equal number of donors according to the population. So in other words, we have a high donation population in the Carolinas. Why wouldn't, if that number is, I don't know what it is, how many people what's the percentage of the population who are donors?
Well, I'll put it another way, that in our area, in LifeShare, they have about 80 donors per 100 eligible deaths. That number is about 50 to 60 per 100 eligible deaths in New York.
So it doesn't match a percentage of the population. We have the 6th largest organ donor registry in the country in the Carolinas. More than 5 million people are registered organ donors here. States like Montana and Alaska, according to the Associated Press, nearly their entire adult population are registered as donors. In New York, in Mississippi, it's only 40% of the population. Why the discrepancy?
I think that's the crux of the matter, and that's the issue that we need to solve. In my opinion, it's to educate people about the importance of organ donation. Think in general, who thinks about organ donation, or if they would need a transplant, their loved one would? That's not something that comes
well,
day to day.
Why do we think about it? Why does Montana and Alaska, almost all of them, think about it? Why are they thinking about it? Nobody in New York cares.
I think it has to do with educating the public, reaching out, having events to raise awareness of organ donation. Also on a personal level, I think people who have a loved one or a friend that needs an transplant,
right,
they think about organ donation. But a lot of this has to do with educating the public in that area.
So prior to the rule change, those who needed organs in the Carolinas, and specifically livers, waited, I'm told, about 6 months for a transplant on average. Folks in New York waited 4 times as long, 2 years, because there aren't enough donors participating in the program, correct?
That's right.
What do they anticipate that number to drop to in New York, for instance, as a result of the rule change, and how do they see the number here changing?
Well, here we expect the wait times to be longer, And in New York, then the wait times to be shorter because they'll receive more livers from high donation areas. And I think in general that the idea conceptually and ideally is to have equal wait times, and it's not, the wait time is not based upon geography. But that's an ideal sending. There are really other factors that need to be thought of when we do this.
What are we doing here that makes people participate to the level that we participate? I've lost the number here, but I think it's 5 million people are on the registry. I don't know what the percentage of the population is, but what are we doing? I don't walk around seeing billboards for organ donations or seeing a lot of commercials on television for organ donations. Why are we so good at this?
Well, here in Charlotte, we have an organization called LifeShare. That's our OPO, what people consider an organ bank. And these are people that will reach out to the family or friends of individuals who have died and walk them through the process of why it's so important to donate. They do that in a very sensitive manner so that these individuals understand the importance of donation. That kind of face-to-face contact is not done in other places throughout the country. And that is one of the issues that's so important.
I don't want to pick on New York because they're a big city, and it's not fair to pick on them just because they can't defend themselves. What other areas of the country are deficient in organ donations?
Well, and it's true. It's not just New York. There are areas in the South where there are low donation rates. There are areas in California, et cetera. I think the important message here is that people understand the gift of life is organ donation. At a time of a terrible tragedy, something good can happen out that for somebody else.
Dr. David Gerber, who's the head of the UNC Healthcare Center for Transplant Care, believes the number of livers available to patients in the Carolinas could drop by a third to a half, meaning that more patients here will die awaiting a transplant. Do you share that belief?
I think there could be a significant drop. The exact amount is very, very difficult to predict. The concern is that when these models were developed to help transport organs, and these estimates, like you just mentioned, were raised, it's very, very hard to determine if they'll be accurate or not. So let me give you an example. I let you know that with lung and heart, the policy already changed for wider distribution, very similar to what's happened with liver. Mm-hmm. However, what we're seeing with those organs, despite the best efforts to estimate that what would happen, we're seeing that there's increased transportation, increased costs, and there may be even increased organ wastage. So it's very, very important that we at least collect the information now to see if these estimates are accurate.
Given that I know that you're on the same page with Dr. Gerber at the UNC Healthcare Center for Transplant Care, and you work for Atrium Health as the medical director for liver transplantation. Those of you in your line of work, what kind of hue and cry did you put up before this rule change, and why didn't people listen to you?
Oh, well, this is how long do you have? I could just let you know that prior to this change, prior to the lawsuits and the courts getting involved, we met for several years throughout the country to discuss how to change the policy, which we thought there should be a change in the distribution policy. Okay. And we thought we had come up with an agreement. And this was around 2016, where just the physicians and the surgeons throughout the country met and said, let's kind of improve the system. And we thought we did that, and we're sharing about over 250 miles. However, I let you know that for the first time, at least that I'm aware of, there was a lawsuit filed in New York that the distribution policy had to change, and that is when a lot of things happened. We had an agreement. We had a gentleman's agreement to change the policy, but because this lawsuit got the courts involved, it changed, and we followed. We, meaning the folks that didn't want to go to a much broader sharing, followed that lead, and there were lawsuits followed. There was an injunction that was recently lifted to allow this new wider distribution to occur. But there's been a lot of behind-the-scenes work maybe the public hasn't been aware of, a lot of legal battle that probably the public hasn't been aware of, but it's been in the papers, in the news more recently.
In North Carolina, we have an opportunity when we get or renew our driver's license to tell people that we are willing to have our organs donated, and they put a little mark on I think it's a little heart symbol on the driver's license. Does that happen in places like New York and Mississippi where the donation levels are low?
Not as frequently as we hope. And
I mean,
that-
do they ask the question when you go get your driver's license in New York City or in Mississippi? Do they ask?
I can't speak for every state, but most of the states you're mentioning do offer that.
Okay.
That is one mechanism, and I think that's what's so important is to educate the public when they go to the DMV to become an organ donor. Also to let their friends and family know. Because what happens, the person dies, they can't speak for themselves, and now you're approaching their loved one, and do they want to think about organ donation? They have a terrible tragedy that they're thinking of, but you need to know, look, God forbid something happens to me, I do want to be an organ donor, and have that conversation before a tragedy occurs.
In 2018, the federal government threatened to close New York's organ procurement organization because they say it failed to meet the standards used to measure success at collecting organs, and they've been working to improve that performance ever since. But Dr. Gerber from UNC says this new rule in some ways, quote, rewards the underperforming organ procurement organizations in the North. And the implications for us is that we're going to see this surge of livers leaving the Carolinas and going to New York. This rule change happened in February. Has that occurred, or is it too early to tell?
Well, so February 4th, the rule change did occur. So the new policy of sharing over 500 nautical miles is in place. But let me bring up some very important point that you raised. We're all hold to metrics in the transplant world. You can go to srtr.org and look up any transplant program and see what their success rates as far as survival after transplant. Mm-hmm. So Atrium Health, Carolinas Medical Center, UNC, you can look up their statistics. And if we fall below a certain level, we're held to that and can be penalized in one way or another. Mm-hmm. Okay. The organ procurement organizations are not held to a metric. And the concept is that they too should be held to some metric so that they are trying to improve their rates of organ donation.
So we've widened this radius to 575 miles, and I know that there are fewer organ donations in certain parts of that radius than there are in others, including ours. But isn't this a two-way street? I mean, we've been talking about how these livers will go from a high donation area like ours to a lower donation area, and therefore our people who need livers will be the ones who suffer. But if you really need one, is your likelihood greater to get one now that the radius is wider? Because it's going to go now to people who are in the position of needing it, or they will die.
Yeah, so that's an excellent point. And that's why when you brought up the statistics mentioned by Dr. Gerber, let's wait and see. So the way the livers are what we call allocated to the sickest first, based upon a blood test, blood work called MELD score, mm-hmm. and the score ranges from 6 to 40. The higher the score, the worse off your cirrhosis, the more advanced your liver failure is. And so it is true, if we have someone with a high MELD score over 36 or 37, they will keep the organ here.
So there's a chance that this could be beneficial to some.
There is a chance.
Mark Russo, Dr. Mark Russo is with us. He's the medical director of liver transplantation at Atrium Health. We will continue our conversation in a moment at Charlotte Talks on WFAE. Support for Charlotte Talks comes from WFAE members in Northeastern University, partnering with employers to customize professional development programs designed to fit the needs of their organization. Northeastern.edu/Charlotte. And Cat Wealth Consulting, LLC. Martha Cat is a financial advisor specializing in retirement planning for state of North Carolina employees. Online at cattwealth.com. The coronavirus death count in the U.S. has risen to 6, and the federal government is struggling to slow its spread. How much preparation is necessary? What can you expect? Those are the questions that 1A will seek answers to next in 20 minutes at 10 o'clock. And I want to remind you that you can join us for a special conversation with best-selling author Kathy Reichs live from 7th Street Market in Uptown Charlotte next Thursday at 9 a.m. We'll talk about her latest book, her long career in forensic anthropology, and more. And you can get details at WFAE.org/Charlotte Talks.
Hi, I'm Gwendolyn Glenn. Join me for WFAE's Election Day coverage on Super Tuesday. We kick things off at 7 p.m. with our political analysts and reporters and you. Our coverage begins with a special 1-hour call-in program to answer your questions and hear your thoughts and expectations as early results from North Carolina come in. That's tonight at 7 p.m.
It's Charlotte Talks on WFAE and WFHE. I'm Mike Collins. We're here with Dr. Mark Russo, the Medical Director of Liver Transplantation at Atrium Health, and we're talking about a rule change that took place in February that expanded the range of how far livers can travel when they are needed and when they have been donated by deceased individuals and their families to help save the lives of living people who need them desperately. These livers used to stay in a certain region, and now they can go within a 575-mile radius. And the problem with that is, as we would discuss, the fact that in some of these areas that these livers can now go, the donation rate is substantially lower than our own. Does this rule only affect livers, or does it affect all donatable organs?
So the one of the first organs to make the policy change was lung, and this followed by heart to expand the distribution or the radius, and then liver, and now kidney is up for discussion, hopefully learning from some of the discussion that the other organs have been through.
You mentioned earlier in our conversation the worry that the time is of the essence when organs are donated. They can only be maintained so long outside of a living human body, and they have to go from one body to the other very quickly. We have modern transportation. We have airplanes. Why is that a concern? I mean, if you had to put that concern, I think you have 12 hours to deal with an organ outside of a human body. So you can make it to New York City in 90 minutes, 2 hours, maybe 2.5 when you consider the ground transportation from hospital to airplane to hospital. If you had to put that concern on a scale of 1 to 10, 10 being a logistical problem, being a common problem, 1 being very uncommon, where would you put it?
I put it in the 7 to 10 range because I think that, ideally, if everything goes smoothly, that liver gets there within just a few hours. But you have to think about there's unexpected events that occur. There's weather events that occur that you can't necessarily predict. And you mentioned 12 hours. Well, if you were going to be an organ recipient, you wouldn't want your liver or other organ out 11 and a half hours. The sooner it's transplanted, really the better off for the person.
So all the doctors involved all the medical officials involved in making this decision certainly know that to be true. Why do they feel it's okay?
Well, they raise the issue that most of the time these things can be coordinated. It's not that every organ's going from New York to North Carolina, maybe North Carolina to Virginia or closer proximity. But I do think that there are still practical concerns that I just previously raised about transplanting these organs. Plus, every time you do this, usually someone has to get on a plane. There's a lot more travel it's typically our surgeons. They're putting them in potential danger from many more flights. And then, of course, there's the additional cost. And, healthcare, we don't like to talk a lot about costs, but as you, on the previous segment, that healthcare and healthcare costs are a big driver of the economy. And this is really something that has not been, I think, properly vetted about the additional costs with all the transportation.
Well, you brought up cost. There's also loss involved in this, it seems to me, because I know there are fears that hospitals that perform a lot of transplants are going to lose business because these donated organs are going to go out of a region, since you've built your business, and that's what it is, around the fact that we're going to be a hospital that does transplants. And we know that the supply of organs is pretty good in region X of the country. And we can afford to bring in surgeons and build ORs and develop a business around that. Now the rules have changed, and a lot of these organs may be going someplace else. These operations, I understand, can result in around $800,000 in billed charges. Is there a fear among Atrium and other hospitals around the country that this is going to hit their bottom line negatively?
I think there's the potential for the loss of the number of transplants to affect the bottom line. Maybe not as significantly about that. You mentioned the charges are often overinflated to what the actual negotiated cost of the transplant is. Also, we're looking at just nationally, not just here in Charlotte, but nationally, using organs, for example, that we never would have used before. So, for example, if you asked me 5-10 years ago, would we ever use a hepatitis C liver, someone who died and was donated and had hepatitis C and had their liver, we would say, no, why would you give somebody hepatitis C? But now, because the cure rates are so high with the treatment, nationally, many more of these organs are being used to mitigate against some of the other factors that we talked about with distribution.
If some hospitals are worried about a loss of income, would they also not be worried about the fact that they have on staff talented surgeons who can perform these transplant operations? Not everybody can do this. And if the number of operations occurring are decreasing because the livers are going elsewhere, that they won't be able to maintain that staff of professionals.
Well, I think that might be one concern, but it will be mitigated about transplanting organs like I just talked about that we haven't used before. So that's one thing. Or they'll operate and do other types of operations. Unfortunately, there's sort of plenty of work to do that may not be necessarily transplant related. I think the bigger concern is that you may have a hospital in a rural area that does a certain number of transplants and serves a large community, but maybe they only do 40 to 50 transplants a year, and then if they drop by 20 to 30%, that program may close, and then that whole area may not be served, and they may never be able to get to a transplant center. I think that's really the bigger concern.
Kyle on Facebook says, I'm changing my will. Why would I want my liver to travel all the way to New York instead of to my neighbor? Can people specify, if they're organ donors, where they want their organs to stay or to whom they want them to go, or is that something that is out of their hands?
First of all, let me address this. Listen, as we're working through this policy change and distribution, please, the message should be still to donate. Let me make that very, very clear.
Okay.
Still to donate. You're saving a life. Also, this distribution policy is in a state of flux and will be addressed. You can do, in many cases, direct donation to a loved one or a family member. So I think the important message is here, please, Kyle, stay as an organ donor. That organ very well may go to a North Carolinian. Like I said, these predictions about organs flying out may not be accurate. And many times, as you know, predictions about the future are wrong.
Right. But can you specify what you want to have happen to the organs you're willing to donate?
As far as I know, you can still do direct donation to a family member or loved one. I do not think you're able to say, I want this to stay in this state.
On the other side of this coin, UNC Charlotte professor Gabriel Zenarosa agrees with the Organ Procurement and Transportation or Transplantation Network. The network says this will save lives, and Professor Zenarosa calls the new rules a step in the right direction. That's a quote, predicting that it will save more lives nationally and that North Carolina patients could actually benefit because some of them would become eligible for organs donated by people in other states like Pennsylvania, where liver donation rates are also high. What about that?
Well, it's hard to disagree with that because we're gonna see what happens, and addressing Kyle's concern that it may be that actually we do receive organs from other states, but. And comment to the two quotes that you made, they would have said the same thing about the heart and lung new distribution policies. And what we're seeing is, at least with the preliminary data, that's not the case. We might even be seeing increased costs and more organ wastage.
Brian Shepard, who is the CEO of UNOS, that's United Network for Organ Sharing, told NPR recently 100 additional lives per year will be saved by more efficient movement of livers between regions. Targeting the livers toward those folks who are really the most critically ill will result in fewer people dying on the waiting list. And I said at the beginning, there are 112,000 people on average waiting on that list, with only 40,000 transplants on average in a total year. 2018, I think 17 people died every day waiting for a transplant. Why is the need so high?
Well, that's a good question. There's, right now, one of the leading reasons for transplant is something called non-alcoholic fatty liver disease, where individuals may have risk factors like obesity. There's an obesity epidemic, diabetes, where fat gets in the liver, can damage the liver and cause cirrhosis. So I think some of this has to do with general health in the population. Of course, alcohol can cause cirrhosis, and individuals who meet criteria, they can qualify for transplant as long as they've documented abstinence. So between these two risk factors, liver disease is fairly prevalent.
We're talking about livers because of this rule change and because you are the medical director of liver transplantation at Atrium, but livers are the number 2 most common organ donated. Number 1 are kidneys, and the heart and lungs follow below livers. And I think I may have asked you this, but in case I didn't, are similar rules in place for those organs?
So for heart and lung, yes.
Okay.
The kidney is going through some of these changes that we talked about.
And how does the need for livers compare to the need for these other organs?
So you did rank them in the correct order.
Okay.
So because diabetes and hypertension are so prevalent, kidney transplant that damages the kidney, and that's the most common organ
But
transplant.
kidneys and livers can both come from live donors. Is that correct? Because you can
Yes.
bisect, or if that's the right word, a liver and take part of it from a living donor and give it to somebody else. And everybody has two kidneys, so you can take a kidney and give it to somebody else. What impact does that have on the numbers of people who get them, who need them, and who are waiting for them? In other words, if you couldn't have any live donors involved in either of these processes, would these numbers be worse?
Well, they would be worse. There may be about 500 out of the 8,000 transplants that are live donor for liver, more for kidney. The issue is the kidney operation is technically a easier operation than living donor liver transplant operation for an adult.
Under this new system, these livers will go to the people who are in imminent. They're facing imminent death.
They have the highest risk of death.
Before, they would just go to the people who needed them in the region. So could it be argued that this will actually save lives? Because if somebody's on the cusp of death and the liver becomes available and you're in New York and it's coming from the Carolinas, you get it. But you wouldn't have gotten it before.
Well, I think that was what the modeling studies had shown. But these modeling studies are computer simulation models that use the best available data at the time. They don't take into account human behavior, weather, and these other issues we talked about. And as I had said, lung and heart changed their policies, and they're not seeing yet, it might be too early, they're not seeing yet the benefits that the modeling had predicted.
I was reading yesterday that 68% of people in the state of Kansas are registered organ donors, but they also have a higher rate of stroke deaths. Brain death is common for stroke victims and overdose victims, which makes other organs, including heart, kidneys, liver, good options for organ transplants. So the South is famous for being a stroke belt, is it not?
There seems to be a high rate of stroke in the South.
So that's helpful to people who need organs, is that right?
Well, I'll just phrase it another way. Maybe that it's the most common. It's one of the most common causes of death with resulting in organ donation is stroke.
And some people are afraid that these new rules will help the most vulnerable populations, meaning poorer people and others who fall into rural as opposed to urban areas. Why would that be the case?
Well, in many rural. So, for example, in New York City, there might be 4 or 5 liver transplant centers in that general area. But if you look at South Carolina or Mississippi, there might be one transplant program for the entire state. And the concern is that if these organs leave South Carolina or a smaller program or Mississippi, et cetera, and their liver transplant program is unable to stay open, where are they going to go for their transplant?
Right.
In New York, if one of them closes, there's another 4 to choose from.
Spain has the highest participation of organ donation of any country in the world, and that is because you have to opt out of donating your organs. Here, you have to opt in. Should we adopt that system, or can we, given our constitutional rights, adopt that system?
Well, as you can imagine, I'm a proponent for that. You have to opt out. I think that this has been shown beneficial in many places, like Spain, for example. There are some countries like Israel that if you're an organ donor, you might receive some benefit if you ever needed a liver transplant or any type of transplant. So I think that the opt out I would favor.
But can we do it?
Well,
and you're not a lawyer, I know that, but can we do it?
I'll leave that. I think we can do it with proper education of the public, but I'll leave that to the politicians.
There are a couple of countries in which buying and selling of human organs is legal. It is not legal in the United States. Should it be?
I would absolutely not support that.
Why not?
Well, because there you have the wealthy that would benefit, and then people that are not as wealthy not benefit. The same thing with using prisoners or a vulnerable population. I would not support buying or selling of organs.
Where's medical science in terms of offering a solution to this, in terms of either growing new organs, being able to alter the genetic component of an organ currently in your body to fix it within your body? Where are we in that process?
So a lot of this has to do with stem cell research and taking a very early type of cell in your body and say, can we make that into a liver? Can we make that into a kidney? I think we're still a far ways away. If you had, asked me a few years ago, I think that we were getting closer. But the issue with these types of things is that you might hear, for example, a bladder or a uterus is grown. The liver, these are not as functioning organs. Like the liver processes chemicals in the blood. So to convert a stem cell into a processing cell that can function like a liver cell called a hepatocyte is very difficult.
So we can't build an artificial filter that we could implant in a body? I mean, we have heart pumps and things like that. We can't do this with a filter system?
Well, there actually has been a lot of work in what they call bioartificial livers, which would be like dialysis for the liver, and they have not been as helpful as one might think.
What about the use of non-human organs? So there's a lot of discussion about pig organs or pig tissue being very similar to human tissue, and they do use pig skin for temporary grafting in human situations. Is there any way to do this? Because I know that the rejection of animal organs in humans to date has been about 5 minutes. That's it. It has to come out.
Yes. Yeah, that's a xenobiotic transplant. We're using a different species, the pig, in addition to the skin, the heart valve. But again, with the liver, with the complex organ, with rejection, it's not been successful.
When will you know, when will experts know whether their worst fears about these new rules have been realized?
Well, I think we're going to know over the first 6 to 12 months as we collect more data. I think really an important message to your listeners is, look, let's collect the information, see what's happening, see how it's benefiting, and the importance of organ donation. Please be an organ donor.
Dr. Mark Rousseau, Medical Director of Liver Transplantation for Atrium Health. Thanks for joining us. I appreciate it.
Thank you.